Welcome back. With us right now is Dr. Daryl Perlstein. He is the program director of the Hoag Lung Cancer Program, and that is part of the Hoag Family Cancer Institute. Welcome, sir.
Hi.
Nice to have you here today. So you were just telling me that this is something fairly new for Hoag, right? The actual lung cancer program, right?
Well, I think a lot of it has to do with the way healthcare has been delivered in Orange County, where it's sort of a private practice model.
Right.
And what they were looking for was more of a cohesive approach to lung cancer.
Right.
And so I was in Wisconsin. That's where I was for 9 years, and then sort of developed a program there and sort of duplicated it here over the last couple of years.
All right. Very good. Now, what you really want to talk about today is the advancements of precision medicine. So kind of explain that.
All right, well, maybe I should just take a step back and say that lung cancer, there's 4 broad categories of the way lung cancer is treated. Really, it's just 4 things.
Okay.
So my specialty is surgery, so you can do surgery or remove it. You can treat it with medicine, and that would be traditionally chemotherapy, okay, and precision medicine is going to be in that group. There's radiation therapy, which is burning the tumor with radiation, or palliative care. Those are really the 4 main categories. Palliative care is essentially not treating, but treating the patient, making him comfortable. So precision medicine comes under the category of medicine to treat the tumor. So the way medicine was traditionally used to treat lung cancer, it's a very toxic drugs, what we call cytotoxic chemotherapy. I mean, even the name sounds like it might be tough, right?
Yeah.
So it's essentially poison for tumor cells, right, which have a lot of side effects. Well, what we found over the last decade or so is that there are better ways to treat tumor that are more precise to that specific tumor. All tumors have genetic mutations. So if you do a genetic profile of the tumor, you look at the genes, the DNA, and what mutations have caused that tumor to arise, now we have medicines that can get plugged in to treat that tumor precisely. It's sort of personalized medicine.
Right.
And that's what we've been trying to get our patients access to, and now we have that.
So would that mean that if someone has lung cancer, would you take a biopsy and before you start treating them, able to look at that and determine here's more of the precise medicine that we can use here?
Right. All you need is a biopsy. You need a little piece of the tumor. Now, sometimes that's done a biopsy before you do any treatment.
Okay.
Sometimes it's after surgery. You know, after the tumor is removed, then you analyze it. But you know, so for very early stage tumors, if we're fortunate enough to catch it early, usually surgical removal is all that's necessary. But if it's any more advanced than that, then we analyze it, because then there can be what we call adjuvant treatment or additional medicine that we can use to prevent it ever coming back.
What about, I've heard also when it comes to precision medicine that you can more pinpoint the area that needs the medicine and administer it right exactly where it's needed rather than broadly. Is that true?
Well, yeah, but let's think of that in terms of a pathway rather than a location. It's not so much an anatomic location, because these are medicines that are delivered either in pill form, so you ingest them and it goes into the GI system, or it's injected intravenously. And these medicines seek out the tumors, and they block certain pathways that the tumors use to propagate themselves. So you're basically blocking it. Rather than killing the cells, you're blocking their ability to grow.
Okay, and then they just die off? Okay. And using this system, though, this more precise medicine, are there generally less side effects that people get from chemotherapy, which can be devastating? Right.
So the way chemotherapy was traditionally used is, it's, like I said, cytotoxic drugs. It's poison, right? And the poison is going to work preferentially on tumor cells, but there's going to be a whole host of tough side effects on the patients. And we still use those to a certain degree, but these medicines tend to be much better tolerated. They have much fewer side effects.
All right, which is fantastic for the patient, because quite often you'll hear that they may have some form of cancer, but really the debilitating effect is due to the treatment. Yeah, so that's great. And as far as your lung cancer center, this is something that, you know, you said where was it you were back east?
I was at the Medical College of Wisconsin in Milwaukee for 9 years.
And you sort of mirrored that here? that
yeah,
program
I mean,
here?
because so lung cancer, traditionally it's been a little bit under-recognized in terms of the problem. I mean, lung cancer is the #1 cancer killer in the United States. It's the #1 cancer killer in Orange County of men and women.
Right.
Lung cancer kills more women than breast cancer. Few people know that.
Right.
So it's a huge problem. And the best way lung cancer is treated, we've found, is by what we call a multidisciplinary approach. So it's doctors from different specialties working together to tailor an approach to each patient, because usually patients benefit from more than one modality. And so what we've been able to develop here in Orange County, which I did in Wisconsin, now we're doing it here, is all of the doctors are working together in a multidisciplinary fashion. So every patient is treated like an individual, and we use all the different modalities to treat their disease appropriately and most efficiently.
And it's interesting you bring that up, because I don't know if I want to use the word popular or whatever it is, but the point is, when it comes to like breast cancer, and of course the hundreds and hundreds of programs throughout the country, the marches and the Corman Center, all that, it's the one people think of most, prostate cancer as well, that they donate to, because it's got big marketing behind it. And I'm not denigrating that, but when it comes to lung cancer, I think most people, if you ask them, you're going, oh, well, so many few people smoke nowadays is what they used to. It's probably almost gone away, and that's not the case, right?
Well, of course not, and so there's still a large percent of the patients that are either smokers or former smokers. Right. And most patients with lung cancer are not current smokers. Most of them are former smokers, and a larger percentage of them now are lifelong non-smokers. We're not even sure of the reason for that. But so there's been a strong anti-smoking campaign in this country, and that's necessary, right?
Yeah.
You don't want kids to smoke. People are smoking, you want them to quit.
Right.
But they use a lot of fear and shame in the anti-smoking campaign. You see it in the commercials.
Yes.
And one of the problems I struggle with is there's a spillover effect into the way we look at lung cancer patients. There's a behavioral component to lots of the disease we treat, right?
Right.
Coronary artery disease, diabetes, AIDS, on and on, right?
Right.
So lung cancer is no different. And the message I want to give is this is a huge problem. Lung cancer takes 160,000 lives in this country every year, year after year after year. Think about that, 160,000. That's what, 10 times the population of Laguna Woods Village, right?
Yeah.
Right.
Yeah.
Every year. So it's a huge problem. And I think we need to recognize that. And what we found is if we catch it early, we treat it appropriately, we can really improve the survival of this disease.
Yeah, I think that's fantastic. And I hope that, moving forward too, you mentioned how many people get lung cancer, they've never smoked, and finding out the reasons why. Is it the environment? Is it hereditary? What it may be. And I imagine that you folks are trying to study that and figure out what are some of the causes here, right?
We are, and I think that's important. But I think, trying to come up with tailored treatments for these patients, trying to catch it early, and now we have effective screening programs in place, which we've implemented at Hoag, where we can screen high-risk patients for lung cancer with annual CT scans, and that's tremendously effective at catching these early when it is curable, All of those are different aspects to our program, and all of it kind of works together to increase the survival of patients with this terrible disease.
What about folks that, as we just mentioned, have never smoked? Are they going to be screened? I mean, they could get the onstage of lung cancer and not even think about, why would I get this? Or not even think about, I don't need to go in and get a screening. I've never smoked. I'm fairly healthy.
I know, and I don't want to scare the audience, because it's still a very small percentage of patients with lung cancer. Right now, it's 20% of the women with lung cancer have never smoked, and 10% of the men. So it's a small number. The encouraging thing is there's a lot of diagnostic imaging that's done for a variety of reasons. And so we're catching a lot of lung cancer incidentally. They get a CT scan for another reason. They have abdominal pain or chest pain. And oh, by the way, they found a little nodule. So you can't screen everybody, because what you're going to find is you're going to pick up more of what we call false positives, right? So you got to be sort of appropriate and narrow down the people you're screening. You can't screen everybody. But because people are very aware of healthcare in this community, we're finding a lot of them early incidentally. And then they get plugged into the system and they get treated.
Yeah, and that's a good point. I mean, when it comes to many kinds of diseases and cancers, yes, you can talk about, well, there's certain causes that you can correlate with it, but sometimes it just is. You can have somebody that has lived a healthy lifestyle, has no family history, and guess what? They have some sort of cancer or disease or something else, right?
Right.
Yeah.
Right.
Thank you very much. I appreciate you coming on. And I want to give you the number here. It's 9497-CANCER or 949-722-6237. Del Perlstein with the Hoag Lung Cancer Program.
Thanks very much for having me.
Thank you, sir.
All right, bye-bye.
We'll be right back.